Hi, welcome everyone. Thank you for being here today. Go ahead and take a moment to introduce yourself in the chat box if you'd like. You can share your name, pronouns, what organization or town, city, state, area you're from, and anything else you'd like to share. My name is Kara Kaikini. I use she, her, hers pronouns, and I'm the Executive Director of the Maine State Breastfeeding Coalition. And before we get started with today's awesome webinar, I wanted to make a few announcements. First, I wanted to share this lovely advertisement for Dr. Jennifer Gelfand's Root to Rise business. They are doing really fantastic work that is individualized to empowering folks throughout pregnancy, preparing for birth, and optimizing their postpartum recovery. And they're based in Scarborough, Saco, and Bath, and available virtually. So I'm sure we'll hear a little bit more about what is offered there. I wanted to let you all know that this webinar is being recorded, and all of our webinars are recorded, as well as our coalition meetings, and can be found on the Maine State Breastfeeding Coalition YouTube page. And you can scan that QR code or go to the website. If you're not already on our email list, I think that we'll go ahead and add you. Once you registered, we can take that email address and add you to our email listserv, and you'll be stayed, and we'll keep you informed about these different recordings and opportunities. Also want to let you know that we are not offering CEUs at this time, but we can send you a certificate of attendance if that is helpful. So after the webinar, we'll be sending an evaluation. And if you would like that certificate of attendance, just be sure to add your email at the end of that evaluation form so we know to send you a certificate. Okay. And just a reminder that our webinars are operated on a very small budget. So thank you for your donation to attend today's webinar. These webinars do come with some expenses, and so we appreciate the support to make these possible to continue to happen. We also want to thank our sponsors. We have annual partners who help us do the work that we do throughout the year: Acceleron, Soft Corner Midwifery, Brandy Rogers, 207 Pediatric Dentistry, Martins Point Healthcare, and Barbara Bush Children's Hospital, and Let's Go Programs of Maine Health. So we really appreciate any donations to allow us to continue to do this work. Every drop counts, like we like to say, and you can consider making a donation, continue to make donations through these QR links if you would like. And if you're also interested in donating your time, we would love to have your volunteer support, or if you're interested in joining our board of directors, we're always welcoming new directors to our board. I also want to take a moment to share that we have our next educational webinar on August 1st is going to be about food and pregnancy and postpartum for Central and South African families. I'm really looking forward to hearing Pauline Lumumba speak about this really important topic for a number of new Mainers in the state of Maine. So you can find information on the Eventbrite page there, and it will be on our website soon. Objectives are there as well, or on Eventbrite so far anyway. So for now, I want to welcome Dr. Jenn Gelfand. Thank you for being here today. Dr. Jenn is a doctor of physical therapy and a specialist in pelvic floor therapy with over 14 years of clinical experience. She received her Bachelor's of Science in Exercise Physiology from the University of Massachusetts in 2003, and her postgraduate degree in physical therapy from Simmons College in 2008. Dr. Jenn is also a yoga and bar instructor and the owner of Root to Rise Physical Therapy and Pelvic Health, located in Scarborough and Saco. Her practice specializes in pelvic floor rehabilitation, including the treatment of bladder and bowel dysfunction, pelvic pain, prenatal care, and postpartum recovery. Dr. Jenn and her team provide evidence-based, individualized care and combined whole-body approach to physical and occupational therapy with yoga-based movement practices to promote lasting relief and optimize our quality of life. Dr. Jenn is passionate about making these topics accessible and educating anyone who will listen about the importance of pelvic health. In addition, Dr. Jenn leads yoga and pelvic floor workshops and educates yoga teachers in training in applied anatomy for 200 and 300-hour yoga teacher programs. So thank you so much, Jenn, for being here. I'll go ahead and stop sharing my screen and allow you the opportunity to share yours. And we'll go from there. Are the windows not in the right places?
I can't find you anymore. Let's see. Oh goodness, we just did this. Let's see.
Okay.
Here you are. I feel like you're in like a different desktop.
I've been there. I think many of us here have as well, if we've been a part of presentations like this.
I
Take
think
your
I'm
time.
nervous. Let's see. Oops.
I can see your desktop now.
Yay.
Okay, there's Canva.
Wonderful. We're
So
almost
close.
there.
Yeah.
Getting into present mode. There we go.
Awesome.
Yay.
Thank
All
you.
right. Wonderful. So I am Dr. Jenn. So thank you so much for that very long just welcome and introduction. I am so happy to be here to talk about pelvic floor therapy, pelvic health, and how we can support our postpartum parents, our new postpartum parents, to have support in healing and recovery. I am, as Kara already mentioned, a pelvic floor physical therapist. I'm also a yoga instructor. And the one thing that we didn't talk about is that I am also a mom of Haley and Kaden. They are 10 and 8. So I've certainly gone through these phases as well, and really passionate about providing care within this time. So I will go through and just talk a little bit about my objectives for today. Um, I really want to be able to help you and support you to learn the challenges that occur in a pregnant body during pregnancy that will then influence postpartum recovery. Differences between vaginal and C-section deliveries in early postpartum. So how one might be recovering a little bit differently if they've had a vaginal delivery than a C-section delivery, and tools to really help your clients feel comfortable and heal well during this time that they're going through so much and they need so much support. I'm also going to talk a little bit about signs and symptoms of pelvic floor dysfunction and when to refer to a pelvic floor therapist. And just a little spoiler alert, anyone who's been pregnant and is, postpartum really would benefit. But I will talk about some of the signs and symptoms that might just bring your attention a little bit more towards someone who could really benefit at that time. I'm going to talk a little bit about why pelvic floor therapy should be standard of care for all postpartum people. I'm very passionate about this as just throughout my career, I've heard a lot of people say things like, I wish I had known, or my doctor didn't tell me it was bad enough yet, or, how come I couldn't have done some of this sooner? So there are a lot of countries out there that do recommend and refer people for pelvic floor therapy postpartum as a standard. And I would say that that helps the narrative, because I think a lot of times when people are struggling with pelvic floor dysfunction postpartum, that often they will think that if they need to go to a pelvic floor therapist, maybe something is wrong or something happened to them. And while it certainly is an event that did happen, it's expected that we would have some of these healing needs and would need rehab postpartum. So I'm really passionate about changing the sort of dialogue around this and just getting the awareness out to everyone and anyone. Also, I will just give you a little bit of information at the end of this webinar as to how you can describe what pelvic floor therapy is like for your clients and patients and people that you support in postpartum. I think that one of the other barriers is that it can feel kind of intimidating or scary, or they've never heard of it before, so they don't really know how to anticipate if they would feel comfortable to go. So I'll share some details about what it's like when clients and patients end up going for pelvic floor therapy. All right. So I'm going the wrong direction. Hold on. Okay. So how does pregnancy affect the pelvic floor? So here's just sort of a list of various categories, and I'll go through some of them in a little bit more detail in a moment. One of the ways pregnancy will influence the pelvic floor is through hormonal changes and hormonal effects. So the changes in estrogen and progesterone, and then the added relaxin hormone can really influence the connective tissue and cause the tissues to be more pliable or lax. Can also influence vaginal lubrication. And then I'll talk a little bit about how that laxity can also lead to decreased stability and strength throughout the joints in the system. Other influences, we have postural changes. So as a person's body, their baby is growing, their body is changing, they start to have some alignment changes in the body, which do influence how the pelvic floor is functioning and how our pelvic symptoms, pelvic health symptoms can show up both during pregnancy but also postpartum. Increased downward pressure just from the weight of growing baby and fluid can really increase pressure on the pelvic floor and pressure on the organs. And I'll talk a little bit more about that in just a moment. And then stress and anxiety and changes in the nervous system. Um, they influence how the pelvic floor is functioning. Our pelvic floor is very connected to our central nervous system, just almost like our jaw and our, maybe if we had teeth grinding that is subconscious, we also can be really holding tension within the pelvic floor during times of being in more of a sympathetic nervous system flight or fight state. And big life changes can bring that among hormonal changes and lots of other things. And so we may see some changes in the pelvic floor due to that. And kind of going along those same lines, social and emotional changes, life changes can influence that stress and anxiety and that nervous system state. All right, so just a little more detail around the changing of posture and changing of alignment and how this can lead to challenges within the pelvic floor function. The increased downward pressure, so the pelvic floor muscles, which I'll talk a little bit about the actual specific anatomy in just a moment, but the pelvic floor functions in response to pressure. So if we have extra pressure coming down on these muscles, then we might have this overactivation of those muscles sort of just chronically throughout pregnancy that then can carry over into postpartum. And then increased pressure on the bladder and rectum will also often leads to bowel and bladder changes, potentially symptoms of frequency, urgency, leaking, constipation, various conditions that could be, maybe it's like the final straw is this additional pressure. Maybe there's other reasons. And sometimes it can just be that pressure leading to those symptoms as well. And so why I'm bringing this up today is because these postural changes can lead to changes in function that are from pregnancy that then carry over into postpartum. And so once we deliver baby, our body still is carrying around a lot of those functional patterns that it learned during pregnancy. And a lot of the tissues and the bones are still sort of in that pregnant alignment in the early postpartum period. So we can have an influence on the pelvic floor, but we can also have an influence on stability of the pelvis and the pelvic ring. I'm going like this because I have my pelvis is over here. So I'm kind of making a pelvis with my hand, but you can see, if you can see me in this little box, I'm not sure if you can too well, but the stability of this pelvis and the pelvic ring is really reliant on the stability and the function of the core, as well as the ligaments and those tissues that can be influenced during pregnancy. So more to come on that as well. All right, so now I'll get into a little bit more of the details. I'm sharing this with you because when I start talking about tips and tricks and tools to provide your clients, I think it can be really helpful to have a visual because a lot of these things can feel simple, but they can also feel like, how is this really going to help me? I find that a lot, like, how is breathing just really going to help me improve my pelvic floor function? So I think if I describe this to you, it will be the most helpful. I love this little diagram on the right. I use it all the time and I'm often sort of showing it with my hands a lot. But you can see in this diagram that at the top of our deep core, this is this little sort of image is really this shape of a canister or a container, which is really what our deep core is. Our diaphragm sits at the top. So that's in the lowest part of our thoracic cavity, at the sort of bottom of the rib cage. And then we have our pelvic floor that sits inside the pelvis. And so if we keep it kind of simple for a moment and we think about the diaphragm that sits at the top and the pelvic floor on the bottom, we have this motion that happens with breath. And so when we take a breath in, the diaphragm is going to lower down into the abdominal cavity, and the pelvic floor muscles are going to lower too. When we breathe out, we have the pelvic floor muscles that lift, the diaphragm lifts. And so with breath, this is our movement within the deep core. And so it's kind of nerdy, but I think it's really important to visualize, because then we can understand how if we take a breath in, we're going to be asking the pelvic floor muscles and the diaphragm to lower, lengthen, and open and expand. And when we breathe out, we're going to be having this natural sort of engagement and lift. So we can utilize our breath as a tool in pregnancy, but also in postpartum, to really help support our healing system and our healing body. And the breath is really the primary, like, biggest, most important part. And so not only do we have the diaphragm at the top and the pelvic floor at the bottom, but we have this deep abdominal layer called the transverse abdominals. And those muscles wrap around like a corset and create sort of the horizontal or the transverse aspect of that canister. Okay, so if I haven't lost you yet, if you take a breath in and your abdominal wall expands outward and lengthens, that is what's happening with the pelvic floor too. So ideally, we're getting this like expansion, this sort of balloon shape on the inhale, and then the exhale is coming together. And so when we don't have the same kind of space in pregnancy, let's say there's more pressure, there's not as much space in the cavity here, we don't have as much movement. And then if we're also holding tension within the pelvic floor or in the diaphragm area, we're not going to have as much movement. And so then in postpartum, we've had these patterns that have come along the way for us. And we might end up having not as much ability to have that motion and that movement of the pelvic floor, the diaphragm, and the abdominals. And you'll learn in a few moments, some of you might know already, but why this is important in our pelvic health and our function, to be able to have all of the mobility and the control and stability. And so we really need to have this system in an ideal alignment and really connected to breath. So we'll talk more about that, but that's sort of the nerdy part of the anatomy. A couple other pieces here before I move on. Yes, I'm just going to go back this way for a second. Okay, I'm going to go back to the slide before this, but just because I am in the anatomy aspect of this, I just want to introduce the pelvic floor by itself. So this model is also what you can see on your screen. And so it's basically our pelvic ring. And then in the base of the pelvis, we have our pelvic floor muscles. So we have this deep layer that you can see. I'm kind of mirroring the diagram there. You can see that there are multiple muscles in there in this deep layer. And then for any of you who can see my screen, I'm small, but this is the outer layer here. This is a female pelvis. So you'll see there's the urethra, the vagina, and the anus. And the pelvic floor muscles are wrapping around those openings. And this outer layer is more sphincter-like. So those muscles are going to wrap and squeeze and close those openings. And they're also going to open and lengthen and make space during those openings. So we need all of that to be happening for function. I also just like to highlight there are nerves and fascia and blood within this area too. So it's not just muscle, and all of that can be influenced. And as I kind of mentioned, the pelvic floor muscles, they don't work alone. So they are working together with the diaphragm, the abdominal wall, in that's what we like to call the deep core canister. I'm just going to go back and just go back to this one last screen here, just the influence of the pregnancy on the pelvic floor when it comes to the social and emotional changes. I guess I had already kind of said this, but just touching on that, some of these patterns in pregnancy then start to manifest in the actual muscular tissue. And so as we're holding that tension, then the tissues and the muscles and the connective tissue can become taut, and then we can have challenges getting that nice motion. And the underlying driver could be from some of the nervous system and the emotional pieces. So just something to think about. Okay, I'm going to pass through there and just kind of come back to the functions of the pelvic floor, why we care about it, why we want the pelvic floor to heal well postpartum. So as I've already mentioned, they support the organs. Well, they support the pelvis and they support the organs. So we have stability around the pelvic girdle that we need. These muscles, as they connect and wrap around the inside of the pelvis here and function as the base of the pelvis, they are going to provide a lot of that stability for that part of our body and those bones. The organs that sit right above those muscles, so we have our bladder, our bowel, we have our reproductive organs. They all sit right above those pelvic floor muscles. And what's really amazing and fascinating to me always, every time I think of this, is that there is no bone here in this pelvic outlet. So that, it's good so we can deliver baby through this section of the pelvis if that's happening and desired. But also because, and so this connective tissue and these muscles are really what we are relying on for stability through here. Sometimes we can have the muscles not functioning as well to help support the fascia and the organs. And then we can have those organs pressed down into the vaginal wall and the rectum and lead to what's called pelvic organ prolapse, which is a lowering or a descent of those organs into the pelvic outlet and through those pelvic floor muscles. We also have continence of the bladder and bowel. So the pelvic floor muscles are going to be responsible to help the closure around the urethra and the anus to help with counteracting the pressure from above. And so certainly if we are having incontinence, we do need to be looking at how these pelvic floor muscles are functioning to support so that we are not leaking when we are not emptying when we don't want to be emptying. So this is a real common, I think, when people think of pelvic floor function, a lot of people will think of, urinary incontinence. There are lots of other things, but it's a one that people often think about. Another function for the pelvic floor and this deep core is complete emptying of the bladder and bowels. So that would really be if the pelvic floor muscles aren't able to fully lengthen and open and they're not coordinated to do that well, then we might not be able to have that full emptying of the bowels, which could lead to things like constipation, or maybe not full emptying of the bladder, which could lead to various things like frequency, urgency, feelings like having a UTI, or maybe just feeling pressure in the bladder, things like that. The pelvic floor also plays a very important role in sexual health for various things. A lot of, what we see is pain conditions. So whether it's vaginal penetration, pain with vaginal penetration, pain with having bowel movements, pain with various activities within the pelvic floor and the pelvic muscles, pain with climax. So we are certainly working a lot with people on supporting them in their pelvic and their sexual health. And this comes up quite a bit in pregnancy and postpartum. We'll get to a little bit more of that in a while. And then lastly, just the role of digestion. So outside of just being able to fully empty at the bottom for being able to keep having bowels moving, constipation can be a symptom of closure here, but also just bringing into light the fact that we need all of that nice movement to help pump the fluid through the system, have the lymph and the digestive fluids and the intestines, all of the viscera being able to move well so that we can then have movement through our digestive system. All right, so I wanted to talk a little about the differences when we look at postpartum recovery, the differences between a vaginal and a C-section delivery. So okay, I'm sorry, I got distracted I thought maybe there was something in the chat for me. Okay, so the differences between a vaginal and a C-section delivery when it comes to postpartum recovery. Let me go back. Okay, we want to think about a couple of things. So in a vaginal delivery, we want to think about the pushing time. So how long that birthing person spent in active labor pushing. The pushing time can lead to, if it's a very long period of time, we could end up with a lot of extra pressure or a lot of extra strain on the pelvic floor tissues, the abdominal wall tissues, a lot of maybe intra-abdominal pressure downward excessively that is stretching the fascia that supports the organs. So pushing time is something we want to think of from the longer side, but then also we want to think about it from the short side, because we find often people will say, oh, I only pushed for, a few minutes or something like that. But and sometimes that can work out, but also we want to think about the tissues needing to adapt. And so sometimes if it's a really fast delivery, we might end up with the tissues not having had time to adapt. And then the tearing or trauma to the tissues can be more, than ideal. Other things that we want to think about in the vaginal delivery specifically is position during pushing, and then the position that the birthing person was in during actual delivery when baby came out of the pelvic outlet. That will influence how the bones come back together and how the muscle activations will happen. And so if baby came out the outlet in a side lying position versus, a lying on your back position, all various conditions, it's really helpful to kind of know a little bit about that. Um, Whether or not there were vaginal tears that they're recovering from, and if there's symptoms of prolapse, symptoms and signs of heaviness, pressure in the vaginal area or the rectum, something in the way, things like that. With a C-section delivery, we're looking more at a few different factors. So we want to know, is the C-section, was it planned? Was it unplanned? And or was it emergent? So if we have a planned C-section, we're going to be looking at that the surgeons had time to go and do the surgery. Ideally, the incisions are going to be really intentionally done. There would not have necessarily been any labor prior to that. So it's generally a little less on, just influence on the body, certainly still a major abdominal surgery. But then if we're looking at unplanned and emergent C-sections, this can, just lead us to thinking that potentially when they went in to make the incisions, that they were looking at, time being of essence and potentially not being able to prioritize as well, perhaps the techniques as far as like doing the incision work and things like that. And also if they were unplanned or emergent, the birthing person could have spent quite a bit of time in actual active labor. And we want to know about that because even though baby didn't necessarily come out the pelvis, out through the pelvis, there's still going to be quite a bit of influence on those tissues during labor. Just to highlight that the C-section is a major abdominal surgery. They're cutting through 7 layers of tissue. So we just want to think about that when we're looking at helping our clients heal, is that, and our patients, is that the incision is one thing that we can see on the outside, but the scar tissue is really going quite a bit deeper and also has the ability to travel. And so that scar tissue can move and wrap around the bladder and the bowel and the various structures and tissues inside, and also really closely related to the pelvic floor, as the incision of the C-section is usually right above the pubic bone. So we just want to think about the fact that it is a major abdominal surgery. Another reason that it is very, very appropriate to have some rehab. We also want to think about swelling, mobility limitations. I'll talk about a little more in a little while. Pain medications, all side effects of the pain medications, and also just the fact that pain is going to most likely be a factor in the early days and weeks. Slower return perhaps to loading the body, getting back to, exercise. Although most people are, they're left to go lift their baby in the car seat and all of those things right away. But also just identifying that, post C-section, there is a healing process that that needs to happen from the surgery. Okay. All right. So I'm going to go to the next slide. I'm going to start with talking about some tips to help you here to support your clients. And I'll go through starting, but I'm going to start with breath. Mindful connection to breath. So, whether or not your patient or client is recovering from a vaginal delivery or a C section delivery, connecting to breath can be one of the most powerful things, the most accessible thing, like I guess technically, although not, it doesn't always feel that way. And it can be started immediately and even prior, right? And so I think that it's really important to come back to, what do we have? What are our tools in the moment? So now, as we've talked about how the pelvic floor functions and how we really want to regain and restore and optimize that movement and mobility, taking connected breaths can be so important. So I often will have people, use feedback that helps them. You can see in this picture, she's clearly not early postpartum there, but feeling your chest, and this might be a nice time after I'm rambling here about the pelvic floor, but this might be a nice time to connect to breath. So placing a hand on the chest and a hand on the abdomen and taking a breath in and noticing as you take that breath in what it feels like underneath your hands. Notice if you feel your hands move. You might notice if you feel one hand moving more than the other. And then you might notice if you feel one starting more like sooner than the other. And the hard part is, of course, most of us, or at least I, while I'm talking, is going to feel quite a bit of breath up in the chest. When we've been pregnant for 9 months, there's not as much space, so the chest breathing is pretty common. And then if we're in pain or we're thinking about other things, right, we will most likely be breathing up in our chest. And so just regaining that connection back to breathing down lower can be really powerful. I like to help people try breathing in different positions because sometimes a particular position is just a position that isn't allowing for as much connection. So, like one person might feel more connected to their breath in sitting versus lying down versus um, side lying is a really great one. So, just inviting your clients and your patients to start to connect to their breath. I like to think about finding times that are like connected to something else. So in early postpartum, we're so structured to like diaper changing and feeds and things like that, focused on the baby and those things. And so, can we guide our patients and our clients back to maybe connecting to those routines that they're starting to get into? Um, to connect again, maybe 5 breaths after a diaper change, or 5 breaths before a feed or after a feed. Often I think about maybe during a feed, seeing if you can breathe into your baby. If the baby is applying pressure to the abdomen or things like that, just to really wrap it into things that are already happening. I think you probably also all know if you've been working with postpartum clients and patients, in that we don't necessarily want to add on a to-do list for them at all at this time, but we want to support them. And so even if it is just a reminder to, how is your breath right now? Where do you feel your breath in your body? Is so important. And then the other piece here is in post C-section. I just wanted to add in a little piece that I like. I like to think about breathing into the scar. A lot of times it is challenging to emotionally want to touch the scar. Maybe you have to gauge your patient and your client if they are feeling ready to think about their scar. But if they are, breathing into the scar can happen from the day one moment, whatever moment, and they're ready to start tuning in. So we can think about that as like mobilizing the scar from the inside out, which then can help with just, the more we can do that, the less sort of scar tissue starts to lay down quickly. Because one of the things that we want to think about is how we can reduce the risk of the scar tissue laying down quickly so that we can help improve the function. So just starting with breath early on is gentle enough. We don't have to worry about the scar healing and things like that, to just be connecting from the inside. So I hope that's helpful. This is a longer slide because I get really excited about this. We at Root to Rise do 2-week home visits, or virtual visits, actually. They used to be home visits, so they're virtual now. But we meet with our patients and we talk about all of these things. And they're really simple, but they're so important. So, thinking about how our patients and our clients are sitting. And so, of course, they're thinking about their baby. They're very tired. Um, but we want to think about how can we set them up for success and so that their system can heal. Because if we find that it's easier or we're just coming into a chair all rounded, of course, baby's here, maybe we're body feeding, right? And we're rounding in and the pelvis is rounded, then we have the pelvic floor muscles and the rib cage not really stacked on top of each other and both pretty tight. So then we can't get that nice movement again. And so helping to support our clients and patients with finding ways that we can sit with the ribs over the pelvis, the hips a little bit higher than the knees. I like to use a blanket under the seat and just to lift the hips up a little bit and a roll in the lower back. And then just a reminder to have people try to rest their feet on the floor, because studies have shown that lifting the heels can lead to overactivation and tightness and tension. And so it can also help us ground into our nervous system. Body feeding, pumping. So looking at how we can support posture there, using hands-free pumps, supporting with pillows. I love the breast friend pillow with a pillow underneath. But as this might not all be new information for you, I just think coming from the lens of pelvic floor healing, we want to think about, bringing baby up to, a level that then we're not rounding so far in, and being consistent with that can then actually stack that deep core canister and help with that healing process a lot sooner. And then in standing, we often find that we still have the pregnancy posture. So again, I don't know how well this visual will do. I'm not very far away from the screen at the moment, but often we find that in pregnancy, we end up thrusting our hips forward to support weight of baby. So we can come into postpartum holding our baby in this way or locking our knees out. And so just kind of reminding our clients and patients to soften their knees, to try to keep equal weight through both their feet, things like that, just to help with that early healing. Okay. So movement patterns. So those were more postures. These are more movement patterns. So getting in and out of bed. If you're somebody who is working with your patients and clients really early on, you might be seeing them getting in and out of their own bed. But this also goes for getting up and down off the floor, all sorts of things. I really recommend people log roll. Even though it can feel like, oh, I was having to do that so much in late pregnancy. Now I want to just get up, straight up. But when we log roll to the side, we can help with decreasing the pressure. The tissues are still very, weak and healing, and we can connect to our breath and our core in this way and support. So before I go through the other functional movements, I just wanted to talk a little bit about how we can use our breath to connect to our core early on in a way to help stabilize and support and reduce the risk of sort of increasing pressure on the tissues, reducing risk of things like diastasis recti, which I'll touch on in just a moment, and prolapse and things like that. So when we take a breath in, we can start our system with sort of preparing. When we breathe out with intention, we get this natural drawing and coordination and connection of the pelvic floor and those deeper transverse abdominal muscles. So if we take an inhale breath and then exhale and lift something, or exhale and push, or exhale and pull, we're going to be able to recruit that natural connection to our core. Will help to kind of navigate and support those pressures without having to clench and hold. Because if we're clenching and holding, we're not really allowing for that motion that we need. And so when our clients are going to lift their baby or lift the car seat or get out of a chair, we can just kind of cue them to take an inhale breath first, get their feet underneath them if they're coming out of a chair, and then exhale as they come up. Or to lift their baby from the floor, to inhale down into the squat and exhale up. And even if we're not being more specific than that, it can be such a game changer. The amount of patients we see that, 6-8 weeks postpartum, they're like, oh my gosh, I've been holding my breath the whole time. I didn't even think of that. because why would we? We've been thinking about having a newborn. And so just kind of cueing people back into this, it feels so much more supportive, and it can really make a huge difference and not have to be super fancy. Um, okay, and then the other thing that we often will think about and look at are diaper changing tables, ergonomics, the height of the table, getting people in like a little bit of a mini squat position while they're changing the diaper instead of sort of just like locked and bent over, potentially like holding their breath and things like that. I would say to try to avoid the bed if possible. I'm not really into the word avoid when it comes to things, and also in early postpartum, you know, we have to focus on the wins. But I would say that, if we can start to set up routines for success, then we can accumulate some more optimal patterning and things like that. Okay, so I just wanted to go over a few things around bladder and bowel habits. Um, Hydration, we usually will recommend something like half your body weight in plain water per day in ounces. That should say ounces on that screen. It's such a generalization, so that is there's going to be a range based on, for producing breast milk, if it's really sweating a lot, if it's really hot, all sorts of reasons to kind of use that in context. But hydration is going to be really important so that we can try to reduce constipation, as well as just improve, bladder function and healing process as well, energy, so many things. Posture on the toilet. So making sure that we're reminding our clients and patients to relax their feet on a stool. I say the floor in this, but actually the next bullet down is squatty potty, and it's a nice low hanging fruit. It's really, really helpful. It just allows the pelvis to get into a position where the pelvic floor muscles kind of relax, or they move out of the way from the rectum a little bit, and the rectum has more of a straight line down, and so it can be more effective and helpful to be using a squatty potty for bowel movements. That goes for everyone, not just postpartum people. But having a relaxed, non-straining routine with bowels is really important. Again, for bowel function, just consistency of the stool, making sure we're getting fiber, avoiding just in case voiding. So here's another avoid, but mostly just thinking about the things that we can do. So it can be often we might get nervous that we're going to get like nap trapped and then go to the bathroom when we don't have a signal. And we really want to listen to our signals and make sure that we are actually voiding when we have an urge signal, because otherwise we can start to train the body to start sending those urge signals, but it's more habit based and rich and routine based, and then that can drive a whole lot of different complications. So the lowest hanging fruit is when you don't have an urge to go, try not to go. Even if you're going in the car somewhere, try. And then bladder irritants, I have a little picture there of seltzer with oranges. I would say that, of course, most people are looking for some caffeine postpartum. We're obviously being reasonable about all these things, but looking to see if there's anything that in somebody's consumption that is really extreme, or that might be contributing to symptoms of bladder irritation, feeling like they have to go all the time. Maybe leaking, that it's like the final straw that we're having these bladder irritants. So more to come on that, and we can talk about it a little bit more at the end if you're interested too. Okay, so I like to do this one in like a sort of guessing, like you guys can guess, but in this format, I'll just kind of give you some of these statistics or things we look for normal bladder function, just because I think it's interesting for all of us, but can be really helpful as like a barometer for where your clients are, right, in their function and where they might need to go. So we're looking at trying to go to the bathroom to urinate 5 to 7 times a day and 1 time at night. It's definitely there's a range. We want to look at context, but that's sort of our range that we look at. Going for 8 seconds. So we often will have our patients go to the bathroom and count their stream in seconds to just get some estimation of how much volume. Being able to go every 2 to 4 hours, not going like every 30 minutes, or having that urge every 30 minutes. And the same thing, like we really don't necessarily want to be waiting 5 to 6 to 7 hours to void. So we're looking at trying to find that place in the middle. The voiding should be relaxed. There are a lot of times where people are feeling the need to strain or push their pee. That can be habitual, or that can be because there's something going on. There should never be any pain, and there should not even be a little bit of leaking. So we often will get from people, oh, I don't leak, but just a little bit when I sneeze or something like that. So just kind of bringing it back to there really shouldn't be any leaking. I should say, though, in this slide, it says ever. The first couple days postpartum, maybe the first week postpartum, especially if there's been, perineal or vaginal tearing, things like that. But we're looking at once that starts, after those few weeks, we shouldn't really be seeing leaking at all. So I have a list here of signs and symptoms of pelvic floor dysfunction. I've talked about a lot of them here. So I'll just kind of go through. So urinary and fecal incontinence, a lot of people will think of the urinary. We're not always thinking about the fecal incontinence, but that could be smearing on underwear, excessive wiping, not being able to get clean, all the way to not being able to hold a whole bowel movement. Urgency and frequency of bowels and bladder as well. So just having to go quite a bit, or a really strong urge that comes out of nowhere. Prolapse symptoms, which I've talked about. Pain with sitting, that is a big one postpartum, especially post-vaginal tear or perineal tearing. Pain with intimacy, pain with intercourse, all things that are common, but things that shouldn't persist, that we should be supporting them with. Low back pain, hip pain, pelvic girdle pain, tailbone pain, groin pain, pubic symphysis pain, any of these pains are things that are going to be, the pelvic floor is so close to these joints, the pubic bone, the tailbone, the low back pain, or the sacrum, the lumbar spine. And so these muscles in the system are so interconnected and interrelated. Then I've talked about constipation, the excessive wiping. And then one other piece is the diastasis recti, which I could do a whole webinar on, but it's just a widening of the abdominal muscles that is natural and normal during pregnancy. The connective tissue stretches to make space for baby. However, it can be problematic when that tissue doesn't become dense again and those muscle bellies don't close again in a way that can help support the abdominal wall with their function. So we are working with people quite a bit. If they have signs and symptoms of what the name on the street these days is called coning or doming. But when it's really, we see that bulge of pressure leaking out through the midline of the abdominal wall. Okay, so I'm sure some of you might have questions for me on this at the end, but I thought I would pop this in here. What about Kegels? So your clients and patients might say, oh, I've been doing my Kegels while I've been pregnant, or okay, I'm recovering, I should be doing my Kegels, or maybe not, maybe the word has gotten out. But generally speaking, connection to this area, the pelvic floor muscles, is important. We want to be able to understand how to notice if there's tension, how to, activate a little extra if we need to. But we don't necessarily want to be just isolated, doing isolated contractions right from the start. Most likely people aren't going to be doing those well, and they're not very functional, again, because our system is working together. And so just squeezing and squeezing the pelvic floor is most likely going to lead to excessive tension and maybe just some sort of ramping up of patterns that are already existing in the body. So we're generally not prescribing Kegels, especially right out of the gates. There are certain times and places for that. But I always say, doc, stop prescribing them, because people will come in and say, oh yeah, like 100 at the stoplight, or, I do them always, like, at this one time of the day during the commercials. And that can just be really problematic, because generally speaking, that doesn't usually end up supporting the goals. So Mordecai, if you have questions on that, we can talk more about that later. A couple pieces here just around why everyone should really come and see a pelvic floor therapist if they can. I've really highlighted quite a bit of the changes that happen during pregnancy, and then some of those influences postpartum, the delivery as well. So the delivery itself with a vaginal delivery is going to stretch those pelvic floor muscles to their max. Sometimes we hear from people, oh, I'm going to get my pelvic floor strong because I want the pelvic floor to push my baby out. And we have to debunk that myth that we really are getting those pelvic floor muscles to move out of the way so baby can move through. And so those tissues, though, do stretch quite a bit and often do have some tearing in the tissues. So that recovery needs to be supported. We can have scar tissue and pain and things like that. Major abdominal surgery if they have a C-section, scar tissue, and all of that needs to be addressed as well. And then the 6-week postpartum check with the OBGYN and or a midwife or any birthing provider is just not quite enough to guide people back to their prior level of function. So it's very difficult to go from kind of like waiting for 6 weeks and maybe doing nothing to then at that 6-week mark being ready for, I'm going to use an extreme, but like CrossFit or something, right? So we need to really look at the context of that healing process from a lens of pelvic floor function, core function. The OBGYNs and the midwives, the birthing providers are so wonderful. They're not, their skill set, their training is not looking at the specific function of these tissues in a way that's applying them to those activities. And so we have protocols and guidelines to help support people back to their activity. So we highly recommend just at least an evaluation, especially if your clients are looking to get back to higher level activities and want to do that successfully without having a lot of complications along the way. Okay, so I just want to go through if your clients are looking for pelvic floor therapy or if you're recommending it, what does that look like? So it really, for us at Root to Rise, we are really passionate about spending really a lot of one-on-one time with our clients because pelvic health is so multifactorial. So we're looking at talking with people for maybe a half hour, maybe 45 minutes, however long it's needed. We do a 90-minute evaluation. We are asking people about their history. So certainly if someone's postpartum, we're talking about pre-pregnancy, pregnancy, the birth, post-birth, really looking at patterns, symptoms, habits, goals, things like that. We're also looking at how their body functions. We're looking at the musculoskeletal system, their posture, their alignment, what is our baseline postpartum now so that we can help optimize that for recovery. And then we are doing an internal exam. So this is the part where I think people sometimes don't really know how to explain it or what to expect. So it is an internal vaginal exam to start. We also can assess the pelvic floor transrectally or through the rectum, through the anus. In male patients, that's how we do internal. And then we also do that with all our patients actually if there's a need. However, the vaginal assessment is typical for the first appointment or first or second appointment. And so it's not like an OBGYN appointment. We don't have stirrups. We just have a gloved finger. The patients are on a sheeted massage table. And we guide them through the whole thing and describe everything. It's just digital insertion into the vaginal opening, palpation, looking at coordination, checking for scar, things like that. Then we're also going over the functional things they can take home and apply at home right away, things like that. So we are spending a good amount of time kind of getting a baseline of their pelvic function, the other pieces that influence the pelvic floor, and then what they're doing in their daily life and guiding them. If it's the postpartum visit that's virtual, we're often going through a lot of those like logistical ergonomic pieces and guiding them through what they will what they're going to do until they go to their 6-week appointment. And then we see them at 6 weeks in person. And I will just go from there. So I would love to pause here and see if anyone has any questions. I have a few other little quick slides here that I'm just going to just pass through. I already really talked about our frequency of therapy, and then that's really all. So I would love to see if anyone has any questions from my presentation. And I love this stuff so much, and I'm sorry that I only left a few minutes here at the end to leave room for questions. So please do so if you have them.
Thank you so much, Jen. That was really interesting. And I'm checking the chat box here. So Erin has a question. So typical if someone is referred is a virtual visit at 2 weeks and in person at 6 weeks. Is that accurate?
Yes, that is definitely accurate. We will see people in person as soon as they want, but we find that people want to be home, and we can do 99.9% of everything virtually in those early weeks. Yes.
Okay, that's great to know.
Yeah. And I
Um,
would also just say really quickly, the reason we wait till 6 weeks to see them in person is because we will be doing that internal exam, and it's helpful to be able to have them have seen their birth provider first, because they sort of get the initial clearance to have that vaginal penetration. So we like to coordinate that so that we can do that in that first session if the patient is ready and wanting to.
that makes sense. Yeah, and she's asking how many follow-up visits are typical or average?
Yeah, that's the best question, but everyone is so different. It really depends on that person's healing process and goals. We might see somebody, 2 or 3 times. We might see somebody for quite a long time because they're trying to get back into some complex activities, or they had a complex delivery. So I would really say it crosses the gamut, but we're lucky in the sense that we can really be very individual with people. So we're not having to, follow any kind of protocols or things like that. We really meet people where they are. So,
Right. And then Ariana's asking if you have an opinion on Benoit balls or other, oop, I just lost it here, instruments mothers use for Kegels.
okay. So I think that sometimes some of these things can be helpful for connection to the pelvic floor, right? So for biofeedback reasons, so inserting something into the pelvis, inside the pelvic floor muscles, and having some awareness and sensation. The tricky part with walking around with something inside like that is if we have tension in the tissues, we can then sort of support a pattern activation of tension. And so, what I really recommend is the guidance of a pelvic floor therapist to really be able to decide whether or not it would be therapeutic and helpful. Just because sometimes we see people that have tried a lot of these things and they come in and wish they hadn't, because there's so many patterns, and we have to unravel and unlearn, if that makes sense.
Yeah, that's great. Thank you. And Erin is asking, do most people need a referral from an OB or midwife? And if they have PPO or insurance or self-pay, can they make an appointment without a referral?
Yeah. So in Maine, thank goodness, physical and occupational therapists have direct access. So we do not need a referral to have anyone come and see us at all. Our practice ends up liking to have a referral on file. Just we love to collaborate, and we also just like to have. There is something in our license that says after 120 days we need to have some type of referral. So I like it to just do it from the start, but it's not a barrier at all. People can just call, they can book. Um, and then I think the other part too was the PPO insurance or the self-pay. We are an out-of-network practice, but we do have patients using HSA, FSA cards, things like that. And people often are getting reimbursed with our super bills that we provide. And there's a lot of practices out there that are doing that at this point because we're able to actually do that one-on-one care and things like that. And there are also pelvic floor therapists in the area that are in network with insurance as well.
Great to know. And then I know the focus today has been on the perinatal time period, but how far past birth do you tend to see folks, or will you see them to review this?
Yeah, so that is such a wonderful question. I always say once postpartum, always postpartum. There was a woman who was in her 80s that I recently saw that had gone to the gym and had a trainer, and she was leaking, and she was like, I don't want to leak. I'm going to take care of this. And it was like so amazing and empowering to just have her seek care at that age. And she actually had a C-section scar that had never been touched, and we worked on it, and we actually got some improvement, and she got improvement. And so that's the best example of how really it is across the lifespan.
Yeah, that's great. And I like how, and there's so much that I took away personally. And no, it's been 10 years since I had a baby, but leaking tends to be something that's normalized
Mhm.
as you get older, it seems like. And after you've had a baby and like, oh yeah, it's just gonna leak. But I mean, do you have any thoughts on that? Like how to get around that and when, like you said, that no leaking is okay. And so
Mhm.
folks should be looking into some extra care if that is happening at all.
100%. Absolutely. And I think the way we can sort of navigate that from like a paradigm is just to not kind of laugh along. Like I feel like if I'm in a restaurant, I'll hear people that are, at the next table over kind of giggling about how they're leaking because they had kids or because, for whatever reason. And I think that to be like, hey, that's not necessarily something you have to deal with. Like there are people out there who are devoting their lives and their career to supporting people to not have to do that. It's such a huge quality of life piece. And I think there's also an element of feeling like maybe it'll just get better if I ignore it, or not wanting to sort of to think about it as leaking. So I think it's just important to just bring it up as much as we can and just be willing to say, hey, there's help. It's out there.
Excellent. And we have a couple more questions. I know we're a couple minutes past 1, but we'll take these last questions.
Okay.
And then you can all see Jenn's contact info on this slide. So if you have further questions, I'm sure she'd be happy to answer by email or phone.
Yes.
Erin is asking, you mentioned pelvic floor needing to move out of the way when pushing. Could someone who has tension in the pelvic floor prior to pregnancy be more likely to push for longer or have more severe tear? And could women benefit from this prior to pregnancy or delivery for better labor and birth? Great questions.
I
You can
love
tell
that question.
who the labor and delivery nurse is here.
Yes, I love
The
that
lab.
question so much because like at this point our mission is just to try to connect and get to people as quickly as we can, as early as we can for this reason. I even think of like preconception as a wonderful time, even if there isn't a symptom, to just be like, hey, what's my baseline? Everything that you asked or those thoughts are true in the sense that if we are starting out with more tension within those tissues, there is likely going to be more challenge. I like to say that in birthing, there are so many factors that it doesn't mean that A equals B and will definitely lead to C. But if we're seeing those signs early, then it's very helpful and proactive to address the underlying cause of that tension before. Because certainly we're not wanting to come to the birthing day and realize, but also yes. So the answer is yes, but I would say there are a lot of factors.
Thank you. And then last question, are there any suggestions on touching C-section scars? Castor oil packs, massage, when would it be appropriate?
Yes, that's a really wonderful question. I'm not personally trained on the castor oil, but I've definitely heard of a lot of people saying that it is very helpful and great. In the very beginning, we're not doing a lot of actual, at least we aren't doing a lot of touching the scar, but rather touching around the scar. So, getting some connection and decreasing some of that sensitivity, pressing along those tissues around the scar. And then once we see that the scar has healed, and that healing time is usually like a 6-ish weeks, around that, sometimes 8 weeks, where we can start getting on the scar. It really depends on the patient. Sometimes it's sooner than that, depending on the scar, but we can start getting on it and start working on the tissue directly. And we often will recommend people use like various textures early on. So if somebody's having some sensitivity or lack of sensitivity, we might recommend like a little Q-tip, or cotton balls or washcloth or various clothing, just gently and breathing so that we can build some of that awareness and decrease some of that sensitivity. I would say there is a little research right now on the silicone tape. So, and this is coming a little new to me as well, because I was just digging into this the other day, but have been hearing a little bit more objective data on this. There's a Frida Moms one, but using the silicone tape on the scar once the scar has closed, to help with hydration and healing and things like that. So, something to maybe look into.
Yeah. Excellent. Thank you so much, Jenn. This was really, really, really interesting. And I'm glad that we'll be able to have this available for others to see after as well. Thank you all for coming today and for supporting this work and for learning more about how to better support your patients too and your clients.
Thank you so much for your attention, everyone.
Have a wonderful day.
Thank you for having me. Okay.
Stop recording.